Right, why don't we go ahead and get started? I want to thank everybody and welcome all of you to our Lemons to Lemonade lecture for this evening. I'm Margaret Crone, the director of the Maryland Physician Health Program, or MPHP. We're part of the Center for Healthy Maryland, the Maryland State Medical Society Foundation. The center was established in 1976 as a 501c3 corporation to support the charitable, educational, and scientific purposes and functions of MedChi. MPHP's mission is to provide compassionate, high-quality assistance to physicians and other healthcare professionals dealing with potentially impairing conditions in a compassionate, supportive setting while protecting both the confidentiality of the participant and the safety of the public. A little bit about our lecture series. In 2023, we mark the 45th anniversary of the founding of the Maryland Physician Health Program by establishing this lecture series, Lemons to Lemonade, Harnessing Our Strength in Difficult Times. Our goal with this series is to support our provider community by ensuring they know who we are, MPHP, who we are, what we do, and to provide information, too, about topics around health and wellness. I'd like to go into a couple housekeeping details. We very much want our audience to join the discussion, so please put comments, questions, feedback in the chat. At the end of the lecture, I will present what's in the chat to Dr. Hobelmann for answers and discussion. So please put things in the chat. Also, all those in attendance tonight will be sent a link to take the CME questionnaire. Please answer all your questions and then submit it. Certificates will be sent out to you within 10 business days of our receiving your completed questionnaire. Just to note that the certificates are not generated automatically, so you will receive them after you've finished the questionnaire. As always, we really value your feedback and encourage you to tell us how we can improve things and what kind of lectures you would like to see in the future. Okay, now I would like to turn it over to one of MPHP's terrific supporters, Dr. Daniel Nyhan. Dr. Nyhan is going to introduce our speaker tonight. A little bit about Dr. Nyhan. He is professor of anesthesiology and critical care medicine and associate professor of surgery at the Johns Hopkins University School of Medicine. He serves as the director of the Cardiac Anesthesia Division and fellowship director of cardiac anesthesia at the Department of Anesthesiology and Critical Care Medicine. He's been with Hopkins, as he says, for decades. Very important to MPHP, however, is that he's been a member of the MPHP Physician Health Committee for 15 years, 8 of which he has served as our chair. He's also been a member of the MPHP Oversight Committee for 8 years. Dr. Nyhan's guidance and leadership have been instrumental in ensuring the quality of our programming. So many thanks to Dr. Nyhan. Now I'm going to turn it over to him, and he is going to introduce our speaker tonight, Dr. Nyhan.
Thanks, Margaret, and welcome everybody. As Margaret indicated, it's my pleasure this evening to introduce Dr. Greg Hobelmann, whom I know personally as well as professionally. Greg is a graduate of Georgetown Medical School. Thereafter, he completed a full anesthesiology residency program and a formal pain fellowship at Johns Hopkins, and probably encountered, maybe for the first time, one of the things we see too frequently in pain medicine, i.e. addiction. Thus, he went on after that to do an additional residency in psychiatry with a focus on addiction, and this was also done at Johns Hopkins. Nowadays, Greg wears many hats, including being chairperson of the MPHP Oversight Committee. He is the co-CEO of Ashley Treatment Center and Harvard Grace, and he is a highly sought after speaker both regionally and nationally. He is highly sought after for 2 reasons. One, his expertise in the area, and two, as you were about to find out, his speaking style is one such that he is clear, he's concise, and efficient, and will not waste your time. Over to you, Greg.
Well, thank you, Dr. Nyhan, and thank you so much for being such a great friend and mentor for so many years. So tonight, we'll talk about chronic pain. We kind of came up with this name addressing the 90% of what we don't see. And what we're really going to be talking about is people with chronic debilitating pain. That's where we're going to focus. But to begin, we want to review some concepts in pain, explore a little bit of the history of pain management and how it came to be the way it is, and then to discuss what occurs in chronic disabling pain, and then describe what true comprehensive pain recovery is. So what is pain? It's obviously been something that has been, seen and known about for, all of humanity. But I think this was a great description back in 1968 by McCaffrey. He says, pain is defined as whatever the person experiencing the pain says it is, existing wherever he/she says it does. It just speaks to the nature of pain, that it's not objective. The more recent 1979, I think this is the definition that we still use now, is that it's an unpleasant sensory and emotional experience associated with actual or potential tissue damage or described in terms of such damage. And I think the key piece with this definition is that it really hits on the emotional piece as well as potential tissue damage. That encapsulates a lot of that 90% of what we don't see. The neurobiology of pain is somewhat understood, but it is very complex, involving the entire nervous system from brain through peripheral nerves. Pain, as we think about it in terms of injury, is results from activation of peripheral receptors called nociceptors by any sort of stimulus. Chronic pain is caused by changes in the system, so in peripheral nerves, spinal cord structures, and supraspinal structures, and it's not nearly as well understood. There's a difference between acute and chronic pain. I'm sure you all understand this, but it's worthwhile reviewing. Acute pain, typically lasts 3 to 6 months, but really is the result of tissue damage secondary to an injury. And then when the tissue heals, the pain goes away. So chronic pain, it used to be defined in a time, but it no longer is. So now we think of chronic pain as pain that persists on a daily basis for a month beyond what would be considered necessary to heal the injury. So it exists when the problem seems to have resolved. There's a purpose for acute pain, protect the area that is injured. Chronic pain seems to have no purpose. It's much more complex and difficult to manage. And we divide it into cancer or terminal pain. There's an endpoint to it, so to speak. And then non-cancer or non-terminal pain, we sometimes call that benign pain. Many causes of pain. We just typically think of a differential diagnosis. I'm not going to run through these things, but you know what the differential diagnosis might be. The key for this is that very often with chronic pain, we do not know the cause. It is unknown, and we never know the cause. There's a process called chronification. We only understand this so much, but we do know that it involves neuroplasticity. So the nervous system's learning and adapting and changing over time. There are changes in a bunch of different domains: perception, cognition, emotion, attention, learning, memory, motivation. And very interestingly, is we see that pain processing shifts from pain pathways to emotional pathways. Very important point. So as pain becomes chronic, it's really shifting to these emotional pathways. You end up the threshold for nociception, being reduced. So you tend to have a lower tolerance for pain and a greater sensitivity to pain over time. When we think about the prevalence of pain in the United States, it's really prevalent. So it's the number one reason why people go to their physician. And about 25% of adults in the United States are affected by some sort of chronic pain condition. Now, the vast majority of them are not disabled, or doesn't create any sort of disabling condition. But people wake up with pain, and there's a huge burden associated with that. The last time it was really reviewed was in 2010, and it was between 560 billion and 635 billion dollars. And at the time, that was more than heart disease, cancer, and diabetes combined. So a huge burden societally. And I'll review it pretty quickly. But anyway, with regard to the history of pain management, throughout most of history, pain has been viewed as a symptom rather than a disease entity in and of itself. And many cultures viewed pain as beneficial. They thought it was something to be welcomed because in the end, it resulted in good things. Society today is not that way, and it hasn't been that way for quite some time. They were making good progress in the mid-1800s. Pain was then recognized as acute and chronic, so they made that differentiation, as well as differentiation between non-cancer pain or benign pain and cancer pain. Took a step back in the 1920s with the specificity theory, where they believed that the only true pain was the direct and proportional response to noxious stimulus, which means that those suffering from chronic pain were treated poorly. They were seen as deluded, malingerers, drug abusers, and there was very poor treatment for pain and of those people. The treatment then consisted largely of surgery and neurosurgery, as well as psychotherapy. I think the psychotherapeutic portion was good. The surgical interventions were pretty brutal at the time, and they were often not beneficial. World War II was a time of really great progression, and what they saw was that soldiers experiencing injuries similar to civilians and tended to report lower pain levels than the civilians. So, if a soldier was shot in the hand in the field of battle, they tended to respond better than someone having a crush injury and being at work and potentially being out of a job. So they started to realize that there was an emotional and cognitive component to pain as well. And this guy, John Bonico, is really the father of pain management. He was the one who really noticed this, and he came back and opened the first pain clinic at the University of Washington School of Medicine in 1960. And this was a multi-modality, multi-specialty treatment for pain. And they made great progress. He used a biopsychosocial model, comprehensive approach, and of course, at the time, there was a very minimal, if any, role of opioids. And he believed and saw that patients must participate with their treatment. They cannot just simply be fixed. There were a bunch of clinics that followed. Again, they had good outcomes, but most of them dissolved. Not all of them, but the vast majority of them dissolved by the 90s as managed care came into play and balked at the reimbursement for those services. At around the same time, some things were changing with opioids. Again, I think most of you know this story very well by now, but we'll review it really quickly. Throughout most of the 20th century, doctors just did not prescribe opioids for chronic pain. It wasn't done. As attitudes about pain started to change in the 60s and 70s, so did attitudes around opioids. It took a while before opioids were used regularly, but in 1980, Dr. Jens Sternswård from Sweden was made chief of the cancer program at the World Health Organization, and he created the pain ladder. And if you look at the ladder, you can see that the second part of that ladder is using opioids for mild to moderate pain. The WHO also claimed that freedom from pain is a universal right. And with that came a huge emphasis on the evaluation and treatment of pain. So you have providers that are really looking for a solution. They're trying to treat pain in a better way. And there also were there was fear of repercussions, because if there were lawsuits for people who were not treating pain aggressively enough. There were some pioneers that were in palliative care that saw that opioids were very beneficial for cancer pain when there was an endpoint to it, and you can continue to titrate the dose, make those patients comfortable, and they translated that into patients with non-cancer pain, or benign pain, and it became very popular to write opioids as you remember, as you know, for benign pain conditions. At the same time that the insurance companies were decreasing reimbursement for multi-specialty pain treatment, they were paying for, medication, of course, so medical treatment from a medication standpoint. Interventional pain management also emerged as a subspecialty, I think around in the 80s. And then by the end of the 90s and early 2000s, opioids often became a first-line treatment for somebody with a chronic pain condition. Interventional pain, just to talk about that for just a second. What is it when we talk about a pain doctor? What does the pain specialist know? Who are they? Well, it's a subspecialty, as Dr. Nyhan noted, often in anesthesia departments, and most of the pain specialists are anesthesiologists or PM&R docs, but sometimes neurology and psychiatrists can also become pain specialists. It requires a 1-year fellowship, and there's a board certification associated with it. What you learn in your fellowship is you really understand all that we can know of pain currently with regard to terminology, neurobiology, mechanisms, and so forth. We learn to treat acute and chronic pain conditions. And many people, I think the real traction is that this is an interventional program. It's an interventional specialty. So you spend a good portion of your time doing a variety of different procedures to help moderate pain. You also, of course, become an expert in the medications that are used to treat pain. And then you also understand where and when to refer. So, of course, the use of physical therapy is very often a part of treatment, as is psychiatry and psychology when appropriate. But I will tell you, it's often very hard to find a mental health provider who has an interest in pain or who's willing to see patients in pain, because those with the debilitating pain can be difficult to treat. So I would say, a large percentage of patients with both acute and chronic pain can be treated very well by an interventional pain specialist and by primary care physicians and people who see pain. But there's a point where pain begins to affect people in many ways. And it's the 90% that we don't see beyond the physical. There's an emotional, cognitive, and spiritual components that I want to talk about today. When we think about the risks of undertreated or untreated pain, they are vast. I've highlighted a few here. I mean, you could look at the list and just kind of run through it. But when opioids are used, there's always a risk of developing a substance use disorder or relapsing in someone who has an existing substance use disorder. Of course, mental health symptoms are exacerbated. There's an increased rate in suicide. There's an exacerbation of cognitive impairment, particularly important in the elderly. And there's functional loss. And the functional loss is really important with regard to how the process continues in a person with chronic pain. So emotions and pain, and I hinted to this before in talking about World War II, but the areas of the brain that process psychological pain are activated with physical pain. And as pain becomes more chronic, you tend to shift towards those emotional pathways. Very interestingly, the emotional response associated with pain is the most important factor for the development of chronic pain. I think it's worth saying that again. The emotional response associated with pain is the most important factor for the development of chronic pain. So you think about those people in World War II, you have a soldier who's in an environment where they almost expect to receive an injury, or when that occurs, they are still, going to be in that environment, potentially going back out and putting themselves at risk. Whereas somebody who is on the job and hurts themselves at home, they have fears about how they're going to support their family. They have fears about their function and so forth. And the response tends to be a more negative with regard to emotions. And that type of pain is going to more likely turn into a chronic pain condition. So depression and fear avoidance are associated with that chronicity. And as emotions and pain potentiate each other, they produce levels of mental, emotional, and physical anguish. And so these things tend to be exacerbated, or they can be new onset in the setting of pain: depression, anxiety, different anxiety disorders, sleep disturbances, substance, use or misuse. And then often we see an exacerbation of any personality vulnerability that might be there. People who have chronic pain, very often they are certainly not at their best, and we see those vulnerabilities kind of come to light. With regard to cognitions and pain, pain and cognition share common neural substrates, and they're known to impact each other reciprocally. So pain processing interferes with cognitive processes, and vice versa. We see clear deficits in cognitive ability in people suffering from chronic pain. These are things like memory tasks, concentration, and even decision making, judgment calls, and so forth. And besides that, patients who have chronic pain tend to think about their chronic pain much of the time. So it takes up a lot of their time and energy thinking about it. Even if they're thinking about solutions for their pain, chronic pain is on their mind. And at the extreme, it's on their mind, 90% of the time. And then spirituality and pain. Important to note what we're talking about with regard to spirituality. There's more interest in this recently, and hopefully we'll see some more studies associated with this. But when we're talking about spirituality, we're talking about the core of a person's identity and their motivation or meaning for their life, who they are, what they do, and why they're doing it. And so their questions arise as somebody develops chronic pain. Why did this occur to me? Who or what would let me suffer this way? They become isolated from friends and family and have this feeling that no one understands. This is just the spiritual component of what occurs in chronic pain. I think this is probably the most telling slide with regard to what occurs. And this is sort of the cycle of pain. Not every patient with chronic pain experiences all of this. And I always, when I'm treating somebody with this chronic debilitating pain, I say, please, think about this and see where you identify. The more they identify, the more they understand it, the better treatment experience they'll have. But it starts with persistent pain. So pain persists for a period of time. If the pain persists and there's a loss of function, that's really what begins the cycle. So with the loss of function comes a lower perceived and potentially a lower real quality of life. At least in that moment, there's a lower quality of life because there's been change. As noted before, they have a diminished capacity to tolerate that pain. So over time, they become more sensitive to pain and can tolerate it less. Pain becomes a primary focus in their life. They're thinking about that, as I noted in the cognitive section. And with that comes a loss of sense of self-efficacy, their ability to do what they have done throughout the rest of their life. There can be feelings of victimization and catastrophizing associated with that. And then their familial and social roles change. They tend to become isolated, and isolation is really detrimental to trying to get into a process of recovery. And then, of course, there's a worsening of the emotional state. This doesn't happen exactly in this order, but you can imagine these things happening over time. And then that persistent pain gets worse. Their perception of pain is worse, and the cycle continues. We speak of the role of the pain patient. This is sort of what role they take on over time. They tend to have a helpless or hopeless state of mind. And this, again, is at the extreme end of it. But there are very often feelings of shame or guilt associated with their lack of ability to do what they used to do, and the effect this is having on their relationships. There's a sense of grief or loss for what they're unable to do. Of course, their mood and anxiety tend to worsen over time. And this can lead to treatment resistance or denial. Early on, there's a tendency for people to want to be fixed. You go in and see your physician, please help me and fix me, and Very often that can occur, which is great, but it can't always occur, particularly in patients with ongoing chronic pain. And they can have struggles with both providers and loved ones over time. It really becomes a new identity. And to some degree, their sole identity, in the end is that of being somebody with pain and dealing with pain on a daily basis. There can be things that we never want to discuss with the patient, but you can see occurring, and that's both primary and secondary gain. Secondary gain is what we typically think of, and that's the external motivators, that their pain, experience of pain, allows them to be excused from something or gain empathy from others. Tougher to recognize is the primary gain, which are those internal motivators. So, for example, having pain reduces the stress associated with the inability to perform. And that's something that you can get with over time in psychotherapy, but it's harder to identify. The consequences of chronic pain, we discussed all of these, but it's a good way to just look at it. The consequences for both individual and society. You have functional impairment. It can be as simple as sleep disturbance or inability to do household chores, but also those things that they used to enjoy, they might not be able to do anymore. The social consequences are the family and friend relationships that they have that are impacted. As noted, they tend to isolate over time. The emotional disturbances, not just the anxiety and depression, but irritability, anger, and so forth. And then the spiritual malady, losing that sense of purpose, losing a variety of identities that they've held over their lives, and losing just the meaning to their life. And then the socioeconomic consequences are huge. We think of challenging patients, and if you've treated patients with pain or patients in general, but there are those that can be challenging. And what makes a pain patient particularly challenging? And it's challenging for the provider, for the family, and of course for the patient themselves. But these are people that generally continue to complain of pain despite interventions. So their perception of pain continues and often worsens over time. Their function is worsening despite what we are trying to do in providing treatment for them, and they have a deteriorating quality of life. And this is challenging because we are trying to provide care for patients, and to not see them get better is very difficult and challenging. And they can be challenging in other ways as well. If they've developed a substance use disorder, their behavior is associated with that. And in some of those emotional disturbances, states of mind, they can be difficult to work with. There is something called complex persistent dependence, and this actually exists in both opioids and benzodiazepines. We'll talk about it for opioids here. Luckily, we're seeing less prescription opioids. It's not nearly the issue it was 10 years ago, but it still does persist. And we see these patients in treatment. We see patients with chronic debilitating pain, still on opioids and still having a very difficult time weaning from them. So about 20% of people have this complex persistent dependence. They've been on long-term opioid therapy, and they're qualitatively their dependence, physical dependence, is qualitatively more severe. We see that, when we're talking and interacting with a patient. The hallmark is that they're unwilling or unable to taper from long-term opioids, despite continued functional deterioration. And then you can see classic opioid use disorder-like behaviors emerge, because it looks like what we would call, drug seeking or medication seeking. But these patients are truly suffering in a different way. And I will tell you, we're seeing it with benzodiazepines as well, not so much with regard to treatment of pain, but there's a percentage that have an extremely difficult time weaning off the medication. So having, a lot of empathy for these folks and taking time to do it, it can get done. It's just more difficult and longer than we would expect. Really important note here is that The development of this role of a pain patient is insidious and nobody wants it. The patient doesn't want it. They don't see it as they're going through it. The family doesn't want it, and the providers don't want it. So we're not speaking in any negative way about people with chronic pain at all. We should be treating them very much, with empathy. They're not actively seeking the role and certainly shouldn't be blamed for its evolution. And we start to see progress when both the provider and the patient start to understand what's happening here, particularly when the patient realizes that external forces cannot just fix the problem. They start to understand that they have to play a role, and then true change can occur. When we talk about pain recovery, this is pain that has been worked up and has been treated to the best ability of other providers, all the providers, including a pain specialist, and they're not progressing. At this point, really, you want to take a holistic approach, in the truest sense of the word. We're looking to treat the person much more so than the pain. And if we treat the person, the pain tends to get better. So reducing pain is part of the plan, but certainly not the entirety of the plan. Key elements of treating pain and of a recovery program is that we're using evidence-based modalities. That's really a key element of any type of treatment, but evidence-based, recovery-friendly environment does matter, and being able to make connections with folks is really important, and that rapport with the providers is really important. We want to use the minimally effective dose of treatment, whatever that might be, medications, but also any other modality of treatment that we're using. You want to have an individualized and strategic approach. And then really important is to have a continued care plan. So when you work with these patients, on a very intense level for a period of time, if you don't have a really clear continued care plan, the success rate is, of course, going to be much worse. The idea isn't to eliminate the pain at all. It's to reduce the suffering associated with the pain. And with that comes a reduction of the perception of their pain. The pain assessment, just to review very quickly, I put this in here just for a couple of reasons. One is that pain complaints should always be taken seriously. Again, if you look back to the McCafferty's definition of pain, it's non-objective. So we have to listen to the patient and go with what they're telling us. There is no diagnostic test to measure the existence or severity of pain. It would be wonderful if we had it, but I don't think that will ever exist. So of course we take a thorough history, and what's really important is a psychological history. And I think when you get to the point where there's disabling pain, the psychological history is often more important than the history of the pain itself, which has been reviewed, many times previously. And the focused physical exam, they've been examined, they've likely had procedures and so forth, and the physical exam is not very telling with regard to pain. Imaging can be beneficial, but again, at the point where they're in this disabling chronic pain, they've usually had plenty of imaging, but we want to look at all of it. When we think about the recovery process, as I noted, the first step is that patients have to realize that change is needed. What they are doing is not working. And this is a huge sticking point. When we think about bringing someone into a comprehensive program, it's worthwhile sitting down and speaking to them, because if they're of the impression that everything is going really well, and their family, their insurance provider, whoever might be, want them to come into treatment, if they're not on board and they're not going to make the effort to change, they simply won't get better. But once they're committed to changing the way they think and behave and getting into this journey, the process has really started. So then they have to become willing to give up the perceived control that they've built over time, take suggestion, and then with guidance start to make those changes. Things we do not want to address at all, are discussions of whether the pain is real versus fake. It's very clear and obvious. When it comes to people that are on opioids, an early discussion about whether or not they have an opioid use disorder or just a physical dependence is not really worthwhile. They will come to the recognition of whether or not they have a substance use disorder over time, but the key thing is that they agree to come off of the opioids while they're in treatment. Of course, you never want to speak to them or mention anything about being lazy or not hardworking, or mentioning anything about money or attention. That's secondary, primary gain, not worthwhile pointing out early in treatment. So we want to address all of those components of pain, the physical, the emotional, the cognitive, and the spiritual. And with regard to the physical component, we do, in all cases, want to wean opioids if they are on opioids. There is a good chance that there's opioid-induced hyperalgesia. And often we see less patients now that are on opioids, which is a good thing. But in those that still have high-dose opioids, if you wean the opioids over a process of 4 or 6 weeks, they start to feel better if you didn't do anything else. It's getting them through that is very, very difficult, especially in those patients with, the 20% that have a really tough time doing it. Of course, we want to continue with physical therapy and get them moving. So primarily look at range of motion and some mild muscle strengthening. There are things like acupuncture and massage that can be very beneficial. For those patients in whom it works, it tends to work really well. We want to balance their activities, start to get them to be more active in their life. And I put medication at the end. Yes, there's a medication regimen. There are plenty of medications that could be beneficial. They're actually not very difficult to come up with a medication. There are only so many of them that are they're not habit forming. But we certainly want people to use medications that provide more benefit than harm. With regard to the emotional component of pain, this is extremely important in patients with chronic disabling pain. There are a variety of interventions. One, if they need psychological or psychiatric intervention, you certainly want to do that. Particularly what we see are things like trauma, grief, and a variety of mood disorders or what look like mood disorders. You have to address them. And you provide them a lot of support. There's significant benefit to building rapport, and there's significant benefit to building a group of people with whom they can identify. So they're starting to connect with others and understand they're not alone. As a provider, we certainly want to be empathetic and listen actively. And we want to try to use motivational interviewing the most we can. We're trying to overcome their ambivalence about a variety of things in their life. And we do that through questioning and talking to them in a certain way. From a cognitive standpoint, it's often said that the education, the understanding of chronic pain and what's happening in chronic pain is the sort of the benchmark of what should occur. So it really is important to provide that education, to challenge their perceived notions and help them understand what's happening within themselves. It is great to see light bulbs go off as you provide that education, particularly when you talk about that cycle of chronic pain and they start to identify and say, yes, this is what's occurring in my life. Okay, now we've identified what's happening and we can address it. So there can be lectures, homework, and so forth. And cognitive behavioral therapy is quite effective, both at the individual and group level. And the spiritual component. So this really is about giving the patients back a meaning and purpose to their life, reshaping their identity. So shifting that identity from somebody with chronic pain to somebody who is a spouse, a father, a son, a mother, a daughter, some sort of occupation, someone who enjoys hobbies, and has many identities again. The patient starts to make peace with their pain. They start to understand that they can absolutely have a high quality of life and that their perception of the pain will be reduced. So there are some practices that help. I think the most important practice is for them to understand what's happening and to start them behaving in a different way, which allows them to regain this meaning, purpose, and identity. But things like meditation, mindfulness, again, the group therapy and the connection with others is really, really important. And they do have mutual self-help groups that, such as, Chronic Pain Anonymous, that have been very beneficial for people. So as you have, or as patients have gone through this recovery process, you see certain things starting to happen. One is that their sense of self-efficacy, what they can do, what they're able to do, has really become activated again. And they start to engage in their recovery, and they start to engage in the world like they haven't for quite some time. They understand how pain works in the brain. They understand what's occurring within themselves, and they understand that it's way beyond this physical component. Their ability to tolerate distress increases, as does their ability to tolerate pain. But that emotional distress, increased tolerance of emotional distress, is a really important feature that occurs through this recovery. They start to manage their emotions better, begin some balancing their life, and they now again feel connected and less isolated. And the results that we have seen in patients going through these pain programs at places like the Meyer-6 program at Hopkins, as well as at our program at Ashley, can be really dramatic in patients who are willing to engage. We have had patients that have come in and said, this is too hard, and they leave, and then they come back, and the second time through, they have a different level of willingness. And you see people getting out of wheelchairs that they haven't been able to get out of for years. People throwing away the walker, throwing away the cane. And in many cases, they say, wow, the reduction of my pain is 90% plus. If we look at the outcomes of these programs, there are not that much data out there, and some of this is pretty old because these programs existed quite some time ago. But you see an overall mean pain reduction of 37%, very significant. A decrease in the prescription pain medications by 63%. An overall reduction in their healthcare use, and then a reduction in social transfers. Those things like welfare benefits, sickness benefits, and pensions by 63%. So really a reduction of the burden, both individually, to the family, and to society as a whole. What to take away, I think, from this is that the 90% that I was talking about in the title that we don't see is everything beyond the physical pain. And so often that is not seen or not addressed at all. And when it is addressed, recovery, the treatment actually works, but it does require active engagement of the participant. And I do have some references here to review if you'd like to see them. And that is all. Thank you very much.
Well, thank you very much, Greg, and appreciate you kind of muscling through all of this, and everybody for staying on the lecture. If folks do have questions, please feel free to put them in the chat, or if they prefer, if they would like to unmute themselves and ask the question live, that is fine as well. Whatever would work best. And I have to say, I thank you very much for this, Greg. It really is a very hopeful presentation. I think many people who are in pain, feel that lack of hope, of a chance to feel better. But this really gives it, a bump in the hope direction.
Good.
Any questions, comments? Anything anyone would like to say before Greg signs off? All right.
I have a question for Dr. Hobelmann.
Yes.
Yes. So I come from the longer time back. So in the 90s, as you said, and we came to the year 2000. One of the problems was that my academy, PM&R, Physical Medicine Rehab, they said at the Academy meeting of 2000, you cannot go too high with narcotic analgesics. Well, so it led to a situation where we saw patients coming from hospitals. I was doing acute rehab at the time. They come from an acute care hospital on the massive doses of medication. And the interesting thing was, I was very uncomfortable with that, but I couldn't exactly turn off the medications. And these were well over 1,000, maybe even perhaps even 1,500 MME per day.
Yep.
We're talking massive doses. You remember that, Dr. Hobelmann. And I was uncomfortable with it. And so I asked the patients, you must have really terrible pain. How high would you say it is? And they say 8 out of 10. Well, I'd say, well, then the medication's clearly not working at all, is it? So you shouldn't have anything. And then what we found was, as we brought the patients down from those massive doses down to lower doses, the pain levels were always the same, but the function was higher. And the risks of death were certainly reduced. So I'm very happy you're doing this. One thing I would point out, the greatest risk that I found, I'm a mechanic, so I try to keep away from the pain medications totally, but what we found was the greatest danger in the overdosing was the patients were using the medications, staying up late at night, their sleep cycles were totally off, and then they would get confused with their medications as well. And I think that these were great dangers. So I would say that adequate rest would be one of the most important things in pain management.
Yeah, and I think we also understood more about even though opioids don't cause end organ damage, they do have effects. They have effects on your immune system, on your endocrine system, that we've learned subsequently. And so taking high dose opioids over time they do have long-term effects. And yes, I would not say that using opioids is inappropriate for anybody at any time, using them very appropriately. And I think that at lower doses intermittently is the best way to use them. But yeah, I mean, it was amazing to see the doses that people were on up until probably 2015, 2016. See 750 milligrams of methadone in some cases, and the milliequivalents of morphine up into the several thousands. So yeah, I'm glad that's not occurring anymore. But we still see some of those patients who are struggling with the weaning process.
So we do have a couple of comments and observations here. Thank you, Greg. Very nice lecture. Well worth the time. As an individual, and another one, as an individual recently diagnosed with CRPS and still battling STD determination, this was important for me to hear. Another one, I remember when pain was a vital sign and we were told to treat it. A question, what is the role of trauma and abuse in chronic pain patients?
Yeah, well, just to note, I mean, there's so much discussion about trauma, and I think it's important to understand what trauma is and what the trauma response is. But there's a huge emotional component, and the emotional response and your emotional state and those emotional pathways are associated with chronic pain. That's how they're carried over time. So those things are going to exacerbate chronic pain, and they're going to again mutually exacerbate each other. They're going to lower your tolerance for pain and increase your perception of pain. So treating them is essential.
Great. Is age a risk factor in the pain cycle?
I don't know if age is a risk factor in that pain cycle discussed with regard to those different things that happen to individuals with chronic pain, but there are certain considerations for someone of an older age because you are going to see more cognitive difficulty. Of course, you're going to have it's going to be quicker that they're going to have just a decrease in their physical function or ability. So their sense of self-efficacy, confidence level are going to go down potentially quicker. So this can progress more quickly and as people age because of that aging process and what comes along with it.
All right. And I guess if I'm getting this right, what's the role, or is there a role for buprenorphine in chronic pain management?
But buprenorphine is certainly safer than full agonists, and so we're seeing a lot of pain specialists that are using buprenorphine instead of full agonist for pain. I think that's a very good idea because it's a safer medication. There's no doubt about it. So when somebody is appropriately assessed and appropriately treated, and opioids are the appropriate treatment, I think buprenorphine is an excellent option. And I would say that we should be using more buprenorphine than we are full agonists, particularly for somebody who's going to be treated for chronic pain.
Great. How would you assess access to pain recovery programs in terms of location and cost?
They're hard to find. They're hard to access. So it does take some research. It takes some understanding of where to look. They have them at outpatient levels. They have residential programs. They can be in a psychiatric setting like the Hopkins Meyer 6 program, which is an excellent program. They can be in a substance use disorder treatment facility like we have at Ashley. And they can be in a PM&R unit of a hospital. So it just takes some research to find where those programs are and what they offer. Hey, Jill.
Hi, thank you so much, Greg. This is one of two appropriate trainings or lectures on pain, including chronic pain, that I've ever really heard. As you know, the majority of the predominant training, hundreds of thousands of physicians and prescribers have taken the REMS courses, which are, the FDA program, and they're paid for by the opioid manufacturers. Those are counterproductive, I believe. And, they actually state that opioids are effective for chronic pain, and that they kind of suggest that people, regularly consider initiating opioids for chronic pain. So this presentation is just rare. I've taken scores of these trainings, and I, just to see, how prescribers are being educated, and I just haven't ever, except for one other case, heard a really great presentation like this.
Well, thank you very much. And I think it's a good point. I mean, I think we have to really understand that the dangers of prescribing opioids long term and in high doses. And I may be slanted one side, but I think that in very few cases are they truly beneficial long term.
Great. We do have two more questions here. Do you have time, Greg?
Sure. Yeah.
Okay. Can you suggest some of the safer pain medications that may be beneficial in clients with mental health illnesses that may be beneficial in both ways?
Yeah, I think my favorite class of medication is the SNRIs. So Cymbalta, Effexor, that class of medication is very beneficial. Also can help with the mood, low mood, as well as anxiety. Sometimes the anticonvulsant class of medications, things like gabapentin and pregabalin, are very effective, and they can be helpful for anxiety as well. And then you can use things like anti-inflammatory medication. You have to be careful with them. You have to be careful with the use for long term because of the side effects, but they are very effective. And things like muscle relaxants can be beneficial as well. And there are a few other classes that can be used, but I think those are the most beneficial classes.
Great, thanks. Can you say again why pain tolerance decreases over time?
Yeah, it's more of an observation than understanding of the neurobiology of it. But we see that as pain becomes chronic, we understand that this is, the pain pathways are shifting to emotional pathways in the nervous system. And I think the combination of those that changing into that emotional system is what decreases the sensitivity. I'm not sure exactly the mechanism of it, but it's certainly been clearly observed over time.
Okay. Well, we've got several thank yous in here. Anybody else have any questions? Which is better, Flexerol or methocarbol? If I've said those right.
Yeah, I don't think there's one that's better. Depends on the patient. I think Flexerol is going to cause a little bit more sedation But you could try, I would always say with these medications, sort of start low and go slow with regard to titrating the medication up. But I actually, I think the baclofen may be the most beneficial of that class of medication.
Okay. Other questions? All right. Well, I guess we'll wrap it up for this evening. Greg, thank you so much for this wonderful talk tonight. Really, really appreciate it. Thanks everybody for being here. I celebrate all of you who have joined with us this evening for this great presentation. Thank you so much for your support of our lecture series. Thank you and good night.
Thank you very much. Good to see you all. Thanks.